Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. I got a little bit of a special episode for you today. I'm going to run you through 10 examples of the prescribing cascade. And many of these examples, and obviously much more, you'll find in my book, Perils of Polypharmacy. You can find that on Amazon. As well as on Audible, if you like to listen to books as well. So these examples, things that I've definitely seen in practice on a relatively frequent basis. So good reminders for you to really pay attention to new medications. They can often be compensating for adverse effects from medications that a patient's already on. All right, without further ado, let's get into the prescribing cascade example. So, first one is a commonly used antihypertensive medication in amlodipine, and one of the most highly testable and one of the most well-known adverse effects in practice is peripheral edema. So that swelling can result from amlodipine, and I've often seen clinicians try to add a loop diuretic, not recognizing that it's from the amlodipine, the calcium channel blocker, and try to manage that edema with the use of furosemide. So in this situation, obviously to resolve this, we'd look at either reducing the amlodipine dose or switching to an alternative antihypertensive medication. Number two, we'll go with Sinemet, so levodopa carbidopa. One of the potential adverse effects with medications that stimulate dopamine or they are replacing dopamine is the risk for hallucinations. So with the use of Sinemet causing hallucinations, you could see an antipsychotic placed on the medication regimen for that patient to try to help treat or manage those hallucinations. Another great example of the prescribing cascade. Now, typically, patients are going to run into those psych symptoms like hallucinations when the dose of levodopa is too high. And so if we can reduce that dose back to a lower dosage, that can definitely help alleviate some of the adverse effects. Another potential option here is if we have to use an antipsychotic, which does happen sometimes in Parkinson's, we're going to lean on agents that are going to be less likely to block dopamine or have a lower risk of that. Medication like quetiapine, for example, pimavanserin is another example there as well. All right, number three. Let's go with NSAIDs, and there are a bunch of examples here with NSAIDs. GI adverse effects can happen. The case I pulled here was hypertension, so on patients that aren't responding to the addition of blood pressure medications and or we're having to escalate dosages of blood pressure meds, go back in that med list and also ask about over-the-counter medications. Sometimes patients can be taking chronic NSAIDs without us as healthcare professionals either knowing it or asking the right questions and making sure we get that information out of them. So in this situation where we've got an NSAID potentially causing or contributing hypertension, we're going to try to reduce that dose if at all possible so we don't exacerbate that effect. And obviously, get rid of the NSAID altogether would be ideal. Obviously, we can look towards different, pain-relieving medications as well as a potential alternative. We can look at utilizing a topical NSAID, which has less potential for systemic absorption and causing these type of adverse effects. So there's definitely a few different options there to navigate that particular NSAID prescribing cascade example. The next one is also in association with carbidopa levodopa and Parkinson's disease, so metoclopramide. is a medication often used for nausea as well as gastroparesis, so some GI issues. And it has dopamine blocking activity, so it can cause drug-induced Parkinsonism. So the prescribing cascade example here would be metoclopramide, and then 2 weeks, 4 weeks, 6 weeks later, patient is noticing some movement-type adverse effects, and the clinician potentially inappropriately diagnoses them with Parkinson's disease or something to that effect, and levodopa or dopamine agonist or potentially other medications used in Parkinson's disease is added. In this situation, we're probably going to look for an alternative to metoclopramide. Next one is thiazide diuretics. This is one that I encounter on a somewhat regular basis, once a month maybe, in some of the consulting and clinical work that I do. Thiazide diuretics, like hydrochlorothiazide, they can elevate uric acid levels, and that can lead to the prescribing of a medication like allopurinol or colchicine in patients with gout flares. So definitely pay attention to that. To alleviate this problem, we're probably going to switch them off the thiazide diuretic. We've got plenty of medications to pull from that are antihypertensives. One unique one, a good clinical practice pearl to remember, is losartan is an ARB, and it actually has some uric acid lowering type effects, or at least trends that way. So in that situation, that might be a good one to pull from. All right, let's take a quick break from our sponsor, and we'll wrap up with the last 5. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, geriatrics, BCMTMS, or NAPLEX, go check out med101.com/store. We've helped thousands of pharmacists pass their board exam, and we can absolutely help you too. So again, support this podcast. Go to med101.com/store and take advantage of some of those excellent resources. All right, finishing up on the last 5 examples of the prescribing cascade. And I want to remind you, go check out Perils of Polypharmacy on Amazon, as well as available on Audible too. If you want more examples like this, more information about geriatrics and polypharmacy, great book, great read, based off of a ton of things that I've seen throughout my career in clinical practice as a geriatric pharmacist. All right, number 6, anticholinergic medications. Diphenhydramine is probably the most common agent I see used, and I've seen it cause cognitive impairment. When it does this, patients can get diagnosed inappropriately with dementia, Alzheimer's dementia, and then we start a medication like donepezil or memantine, and obviously that can be an issue. Those can cause adverse effects themselves, and we can continue to perpetuate that prescribing cascade. Now, in that situation, let's say you're using diphenhydramine for sleep. Obviously, we need to look for a different agent for sleep. Definitely not a great medication in our geriatric patient population. Number 7, I'm going to go with a little younger population, potentially. ADHD medications that are stimulants like methylphenidate, for example, some of the amphetamine salts. These can cause insomnia. It's well known that these can cause patients to not be able to sleep very well at night. And so you may see, a medication like trazodone added, melatonin, zolpidem, or some of the Z drugs for sleep. Make sure that we understand when the stimulant medication is being given. Typically, in most situations, we've been able to adjust that timing of that medication so it doesn't linger quite so much into the evening and cause insomnia. Okay. Another potential alternative is look for a different medication, to treat the specific condition that we're trying to treat as well. Number 8 is opioids. Opioids are notorious for causing constipation. We often need to do laxatives when we're using chronic opioids or opioids for, 1 or 2 weeks or longer periods of time than that. So this is oftentimes an intentional type of prescribing cascade where we're anticipating that they're probably going to have issues with constipation. But I will say in practice, I see those laxatives get left on board for a lot of the time, even after the opioid has been tapered off and or discontinued. Okay. Remember non-drug interventions here to try to reduce constipation, increasing fluids, increasing fiber, and those type of good things there. Next one, number 9, is corticosteroids. These can jack up blood sugars. I've seen this a ton in clinical practice. Usually it's with higher dosages of prednisone bursts, where we see those blood sugars go up significantly. And to counteract that effect, we may increase insulin, increase dosages of oral or injectable blood sugar lowering agents. So there's a lot of things that may happen on account of this. One thing I really always caution is when that corticosteroid is stopped, if adjustments were made, be really, really careful for the risk of hypoglycemia. Okay. So again, tapering off that steroid, that can be kind of helpful in managing those blood sugars, making sure that we don't, peak as well as trough too quickly. But that may not be possible in all cases. We may just do 5 days of a steroid and be done. But it's a great patient education point to make sure that the patient understands that blood sugars are going to be a little bit more variable while they're taking a systemic corticosteroid. All right, the last one I want to mention is almost an intentional one here again, similar to the opioids with laxatives. Loop diuretics can cause significant drops in potassium, and oftentimes we have to supplement with potassium supplements to make sure that we stay within the normal physiological range. So that is a classic example of the prescribing cascade done on an intentional basis. One really, really important thing is to reassess that potassium supplement if the diuretic goes away. Okay, so that's one way to help reduce polypharmacy. If the patient had edema due to an adverse effect of a medication, and then we add a loop diuretic, but we resolved the initial edema situation in the first place, now we can get rid of the loop diuretic. Don't forget about the potassium supplement if that was added as well. Okay, we likely will be able to get rid of that too. Now we're going to follow labs on that and monitor that, of course, to make sure that potassium level is still okay. But that is a great target that I always utilize in my work in assisted livings and nursing homes and those type of things. All right, well, that's going to wrap up the podcast for today. Hopefully you enjoyed this little break from the usual podcast episodes of a specific medication. Please go to reallifepharmacology.com, get your free 31-page PDF on the top 200 drugs. Great study guide, great refresher. Simply an email is all you need to get access to that. No brainer. Go take advantage of that. If you want to reach out to me, mededucation101@gmail.com, or you can track me down on LinkedIn as well. Eric Christensen, PharmD, BCPS, BCGP. With that, I'm going to sign off for today. Thank you so much for listening. Hope you enjoyed this episode. If you did, leave us a review or rating on iTunes or whatever platform you're on. Thanks again for listening. Take care. Have a great rest of your day.